really excited to be here again today. We're going to get started in a few minutes. A little bit of housekeeping. If you have questions, there is a little question section there. Feel free to send us a message, give us some input or some feedback as we're going. We are recording this, so we should have it available in the next few days for you to rewatch if you'd like. But we're excited to be here. Hi, ladies. How are you?
Good.
I'm great.
Hi, good morning or good afternoon.
I guess it depends on where you are, right?
Yes. Yeah. We're excited to be here.
I just want to point out, ladies, I am wearing purple for our kickoff to National Dental Hygiene Week.
Yes, good for you.
That's great. And I'd like to say thanks to all the people who were going to be doing Gift from the Heart today, and they decided to take their materials and give it to people who could really use them, the PPEs. And some of them are also taking their toothbrushes and stuff to food banks. So I'd like to really acknowledge and thank those people who are really thinking outside the box about what's really important right now for everyone. So I know that that's such a hard thing for Bevan or gang to give up on this day, but it will come again and we'll all be there to help out. So that would be you know, just a memory of a thought of what today was going to bring. So much fun and hope for a lot of people, but we can do it again in a different way.
And I know we didn't plan it that way, but that we're actually meeting and that we've got 500 hygienists with us today to be together and to learn is really cool. So
it's amazing.
It is. Yeah. It is.
Yeah. Well, should we wait a few more minutes, Carrie, or yeah? Okay.
What's the weather like there, ladies?
Lovely. It's sunny. Yeah. It's chilly.
Do you have any snow?
Nice.
Any snow?
Not in Burlington. No. How about Stratford, Beth? No?
No, it was beautiful today. I had my coat on, but I could have taken it off. It was quite nice.
Oh, that's good. Nice. I was out early this morning and I did a nice power walk with my 2.5 pound weights and it was lovely.
That's good.
Yeah, we had our Darby out this morning as well, and he'll be ready to go again by the time I'm done this. Yeah. He already took the insole out of one of my guys' shoes this morning and distributed it all over the front hall. So we have to break that to him when he gets home today.
Well, the sun is shining here in Alberta, but
nice.
Outside of Edmonton, we have a lot of snow, though. My children made a huge fort. It's like 12 feet long. You can enter on both sides, and it's going to be a while before we don't have snow on the ground.
Wow. Sure.
But at least the sun is shining.
That's good. Yeah. Sun changes everything.
Absolutely.
Right. Sunny day.
People still logging in, Carrie?
Oh dear, we can't hear you, Carrie.
If we give them just a second, the numbers are still climbing. So if I give them another second or so just to get registered, we should be okay and ready to go.
Nice.
It's a fun learning curve, learning all this video conferencing now, isn't it?
Adapting with the times, right, ladies?
That's right. That's right. It's what we do. We're so flexible, right?
You know, I think the hardest part in all that we do is trying to use the technology, and you can run as many dry runs as you can, and yet sometimes things just still don't work out. We're still, you know, normal hygienists trying to manage the best we can with all the excitement. So, all right, we are, all right. I think give it one more second here and then we'll get started.
Well, Carrie, I'm just happy that you're the one who's managing all that. It's been, I know that's a lot of stress.
Did everybody hear that?
Yeah, I think everyone's phones are going off right now. So
mine's off.
Yeah.
Yeah, but that was like an Amber Alert thing, but it was for COVID.
Oh, was it? Oh, it is. Yeah.
Well, that should capture everyone's attention.
Yeah. Yes, exactly. It really should. So.
What are they announcing?
Just to everybody stay home.
Oh, Amber
Yeah.
Alert, stay home.
Yeah.
Stay
Well,
home.
we're all participating in that.
It's just
Yeah.
go out if you need to pick up groceries, prescriptions, or medical appointment.
We've been doing it for weeks now.
I know, and you know we've done a good job, and I think just making sure we check in on everybody else to make sure that as we're going, people are safe, and that we do our part. That's the main thing.
Mm-hmm.
All right, ladies. Well, let's get started.
All right. Well, thank you everybody for joining us, and thank you to the RDH View cast for taking the time to be here with us today as well, and to Chrissy Ford, who is from Alberta. And Chrissy, you offer laser therapy programs in Alberta, so we've partnered with Chrissy on that because we now offer lasers throughout the country. Well, not throughout the country, but BC, Alberta, and Ontario. And Beth Parts is our leader here in Ontario for our laser program. So thank you everybody for being here. And I just wanted to read, before we get started, read Chrissy's bio, tell you a little bit about her. Chrissy is a registered dental hygienist, practice manager, lecturer, and founder of a continuing education program and co-founder of a dental hygiene consulting company. As a founder of Advanced Hygiene Solutions, Chrissy believes in a more hands-on and integrative approach with continuing education. She is committed to empowering dental hygienists to create strong patient-centered hygiene programs and believes lasers can play a critical role in helping us achieve optimal health for our patients. Her passion for lasers came after fully implementing lasers into her own practice and seeing the many benefits that can be achieved. She now enjoys educating others with her laser training courses across Alberta. Chrissy is a member of the CRDHA and the CDHA and currently serves on the Competence Committee with the College of Registered Dental Hygienists of Alberta. So thank you so much for being here with us, Chrissy. We're excited. Yeah, we just love the way that you really have embraced laser therapy into your practice, and we're excited for you to share all that with us today. But first, I just wanted to ask, like, what are the benefits of adding laser therapy into your dental hygiene practice?
Yeah, Beth, did you want to start? Why don't you go through and I'll add?
Yeah, for sure. So I think I just want to point out that there are several types of lasers out there, and there's actually a lot of benefits to having lasers in your practice. I'm going to focus specifically on the diode lasers today. And Chrissy, I'm sure that you're going to follow suit with that too. Diode lasers are the soft tissue laser of choice, which is something that we talk a lot about in the full courses, going into the science behind why a diode laser is our preference. So with a diode laser, there are several functions that it can be used for. The first one is LBR. That's the acronym that many would be familiar with, and that stands for laser bacterial reduction. So essentially, the laser energy is being used to reduce the bacterial colonies subgingivally, but also to delay that recolonization. We'll talk a little bit more about that as we go through this. I'm just going to kind of touch on the benefits of lasers. So another one would be desensitization. So lasers are actually causing desensitization because it's changing the viscosity of the fluid within the dental tubules. So again, that's something that I think, Chrissy, we're going to talk about with you a little bit more with your personal experience with that. Yeah. The other thing that's exciting is we can treat oral lesions with lasers. Again, anything that I'm talking about as far as a benefit goes, you want to check in with your regulatory college just to make sure that it's something that's within your scope. I'm just going to give you an overview of the benefits and then leave it up to you to sort of check in with your regulatory body or take one of our courses to find the specifics about what you are allowed to do. So with oral lesions, what we're doing is, whether it's an aphthous ulcer or a herpetic lesion, we're actually using the laser energy to speed up the healing process, but also to reduce the symptoms. So that might be the feeling of pain or sensitivity with the lesions. We're actually reducing those symptoms as well as speeding up the healing. So that one's a pretty exciting one. And the research is still ongoing with what I'm going to say next, but they have found that with herpetic lesions, when you use the laser to treat the herpetic lesion, that herpetic lesion may not come back to that site ever again. So if you've had a client or patient who has this herpetic lesion that's always coming back in that same spot, and you offer a solution, they're going to be your patients for life. So that one's one of my favorites. Another thing that it's used for is, you may have heard the acronym LAPT. So that stands for laser assisted periodontal therapy. So essentially, you're removing biofilm from within the necrotic tissue along the sulcular epithelium. And Chrissy's going to talk a little bit more about LAPT as we continue on as well. The last thing I want to touch on is that lasers are also being used to help treat implantitis mucositis by preserving attachment, or even recreating it by removing the pathogens and supporting healing in the area. So that was a lot. I understand that, but those are just kind of the bullet points for the procedures that we can use the diode laser for.
Now, can I add to that, Beth?
Of course.
Obviously, those are all the amazing procedures that we can do clinically with that, but right now I'm going to take off my clinical hat, and as a manager position, there's a lot of benefits to bringing a laser into your practice that go outside of the clinical aspect as well. So when you think about, we have a lot of dentists on every street corner where there's a lot of competition, and we want to be able to stand out in a way that can actually help our practice. So maybe you're the only area or only clinic in the area that offers laser. That can really help, make you stand out. Obviously, we had a lot of competition in dentistry before COVID going back, when we're back to work. It might even be more so. We're a little, everyone's going to be a little bit more stressed to bring in new patients into the practice. And I find if you can increase your standard of care and your patient experience and have that internal referral system, which I don't know if you know, but that is the #1 way to market your practice, is internal referrals. When your patients are happy and feel that you're taking care and you're bringing in technology that's benefiting them, it really helps your practice growth in the long run too.
Absolutely, I agree with that completely, Chrissy. It's something, again, just separates the office to office. It separates them, but also as a registered dental hygienist with your resumes, having that on that resume is also something that sets you apart, right?
Mm-hmm,
Yeah,
exactly.
we found that at RDHU, we often get offices call us in a panic because they've hired a dental hygienist who isn't laser certified or trained in lasers, and they call and they thought, we thought everybody has that. So then it's like, when is your next course? And we do carry them or offer them more frequently now than before, but before it was like 6 a year. So it's like, oh, you might have to wait a couple months. But so it's always good to have that skill on your resume for when you are looking for work as well, or a new position.
Mm-hmm. Absolutely.
Can you ladies describe or explain to me the difference between LBR and LPT?
LAPT?
Yeah, for sure. Yeah. Chrissy, do you want me to start with LBR, and then maybe you could touch on LAPT?
For sure, sounds good.
Okay, so LBR, so we were just discussing earlier how it stands for laser bacterial reduction. So this is something that is so easy to do. As far as dental hygiene skills go, it's one of the easiest skills, I think, to learn. It essentially just involves inserting the laser tip below the gums by about 1 millimeter. What happens is the principle behind it is allowing laser energy to flow into the sulcus and to be absorbed by the targeted tissue. So how it works is that energy is thermal, and it essentially just vaporizes the targeted diseased tissue. So it's a very, very gentle thermal reaction that takes place, and essentially it causes a temperature rise in that targeted tissue. So the cells, which would be your diseased tissue, or the gram-negative bacteria specifically, start to kind of increase in size with that thermal reaction until they vaporize. That's very simple demonstration as far as what's actually happening below the gums when you use a laser. So the reason I like this so much is because it's fast. It doesn't take very long to do this. It might add maybe 6 minutes to your appointment, 6 to 8 minutes. It's very simple to do. And we've just sort of touched on the fact that it's reducing the bacterial colonies below the gums. So that is benefiting your client because you're reducing the bacterial colonies and delaying the recolonization of that bacteria. But also as clinicians, it's beneficial because it's reducing the bacteria that are going to be released in the aerosols produced. So that's beneficial both for client, clinician, and then your next client coming into the room, right? So it's got a few benefits, but I guess that's a summary of what it is.
And I think after when we all do go back to practice, I think that's going to be a nice thing to implement, just to show that even for the patient perception or the client perception, that you're doing everything you can to bring them in safely. We've implemented lasers, this can be a lot of change for us coming back into practice, but I think that's one that will be very welcomed by clients, to show that you're doing this pre-procedural treatment prior to getting into the debridement and such.
Mm-hmm.
They said we were playing breakfast this morning.
And I think too, now more than ever, our patients are going to be more educated in the whole concept of what aerosols are, right? Before that was our modality of things that we thought about, but a patient, often wondered, why am I doing a pre-rinse? Why are you doing, this procedure? And now they're going to be educated. They're going to want you to be doing these things for them. So I think when you can offer that, like Kathleen said, they're going to feel better about coming in to see you, that you're doing everything that you possibly can from our perspective to reduce those aerosols and bacteria and viruses. And yeah, for sure.
I agree, Chrissy. And I think more than ever, they're going to be open to that message too, right? They're seeing, because sometimes the reservation is, well, it was working before, why are we changing things? And now it's, well, actually, no, we should be adapting. We should be looking at improving and finding new things to make it even better.
Yeah, absolutely. Yeah. Are you done with the LBR, Beth? Do you want me to go on to LAPT? Yeah, okay. So I think with the differences looking at LBR and LAPT, the main thing that we want to think about is, what are we trying to achieve with it? So with LBR, I think of LBR as a preventative measure. We're using it before we see disease, before we see destruction. Our whole concept is so that we're contributing to a healthy mouth. We're reducing the bacterial load. It's done in the appointment, in your standard hygiene appointment. Now, LAPT is a little bit different. We're looking at a sense of an adjunctive therapy to scaling and root planing to treat a diseased active perio pocket. So it's once the disease is there and we see destruction, now we're looking at what else can we do if scaling and root planing, our gold standard, is not doing the trick. There's lots of adjunctive therapies that we can pull out, but lasers and LAPT, if you're able to do that in your province. Now, for those that are wondering, unfortunately, Alberta is the only province that can offer LAPT. At this time, but for the other provinces, it doesn't mean you can't utilize the technology to do that. It just means your doctors are going to do that procedure for you, and you still have the availability to do all of the other procedures that are going to be great for your patients. So with LAPT, the main difference is we're doing it for two different reasons, but we're using an initiated tip. And what that means is with LBR, there's no heat involved. It's painless. They literally don't feel it at all. You're just going a millimeter underneath the gum. But with LAPT, we're activating the tip. So we're activating, meaning we're trying to get a thermal reaction. And the main concept for LAPT is we want to remove the necrotic disease tissue. Now, if you think about what curettage is, so curettage in the form of using an instrument, whether it's a hygienist doing it or a dentist doing it, where our concept is we're trying to remove that disease layer, that epithelial layer that's diseased, so that we can have a healthy wall healing against a nice clean tooth. Now, what I love about lasers is we're able to do that curettage now with the laser technology. And the really great thing is we're only attacking the diseased necrotic dark tissue, and it's leaving the healthy tissue totally intact, which is really, really great. So again, just coming up with new technology that we can do a job that was done with an instrument before, but now using a laser in a better way. The main things that we're trying to accomplish with LAPT is obviously removing that necrotic disease layer, getting de-epithelialization is what they call it. On top of that, guided tissue regeneration is kind of something else that falls under that category. And that's just all about the reattachment. So encouraging a reattachment from the base of the pocket up. And what we're aiming to do is encourage our osteoblasts and fibroblasts to get that healing. And the difference with LAPT is it's not just going to be something you throw into your standard hygiene appointment. You're going to need to plan for it. So LBR, it's a part of your standard appointment. It's just a 5-minute procedure. LAPT is something, you know, after diagnosing and figuring out that there's active disease and making a plan, what else can we do for the patient in this pocket area, and making a plan going forward. That appointment could be anywhere between, depending on how many sites you're treating, anywhere between 30 and 60 minutes. You're either going to book a separate appointment or that's going to be tacked on to a hygiene visit. So a little bit more of a time commitment involved with that and just everything that you're doing with it. Yeah, go ahead, Carrie.
Can you just remind us what the acronym stands for? There have been a few questions that came in just reminding us, you know, LBR, what does that stand for? What does LAPT stand for? If you don't mind just repeating that, please.
So LBR is laser bacterial reduction. So all that we're aiming to do is use laser thermal energy or laser energy to reduce the bacterial load. And LAPT is laser assisted periodontal therapy. So we have an active disease pocket and we're adding an adjunct to our scaling and root planing to treat that active disease pocket. Yeah. Okay, where was it going to go? Oh, yeah. So we have, with that being said, depending on the depth of the pocket, we're going to, how many sites we're treating, the depth of the pocket is going to, you know, determine how long of an appointment you're going to need. But with LBR, it's just you do it once and the next time you're going to do it is at their next maintenance appointment. Where LAPT, depending on the pocket depth, you're actually going to bring them back for multiple visits, 7 to 10 days apart. And the reason for that is we're trying to guide back the epithelial tissue. Epithelial tissue heals and grows faster, has a higher rate of growth than connective tissue. So what we're trying to do is guide that back 1 millimeter at a time, and that's where that 7 to 10 day window comes into play. And with that, then we're able to get a strong, real good connective tissue, that long junctional epithelial connection from the base of the pocket. So instead of just healing and reducing inflammation, we're getting true reattachment, which is
Boy, that sounds so exciting, Chrissy.
Yeah, it is. It's amazing, and I'm going to get into more of kind of the implementation and my results in my clinic later. But it honestly is amazing when you get to see it with your own eyes. I'm one of those people that I'm not going to believe it if I read it or even if someone told me, even if a friend said, oh my God, Chrissy, you have to try this. I'm like, I'll believe it when I see it with my own eyes. And that's why when I get into the story of how I implemented it, that's exactly what I did. I got trained. I was the only one doing the laser until I saw it with my own eyes. And then it was a no-brainer. We got the whole team.
So Chrissy, when would you, how would you implement that in with your scaling and root planing? Like, would you do it at the same visit, or would you, do you concentrate on one quadrant? Like, how does that work?
So, I mean, it depends on what kind of situation you're dealing with. If it's like one localized area that, I mean, it depends too if you've just implemented lasers into your clinic and your patients have never heard anything to do with lasers, you kind of have to prep them for it. You have to, you know, educate them on what you have. The main factor of why you can't really throw it into your hygiene visit in the moment is the time factor. So if you happen to have an opening right after your hygiene visit and you realize, hey, this is a pocket, we've seen no improvement, we still have active bleeding every time, we've been seeing them every 3 months and nothing is improving. You know, maybe you have a 30-minute opening after and you discuss and you let them know about LAPT and you say to them, you know what, I actually have time today. If you would like to try that procedure, we can definitely get that going for you today. Now, the only issue lies, so number one, time. Number one, two, or going forward with how do you break it up? It depends. Has your scaling and root planing been done to completion first? So that's it, and I really want to reiterate that to everyone. And same with any adjunctive therapy. If we haven't done our gold standard properly first, then any adjunctive therapy is not going to be successful. So the very first thing that I always say in my mind is this pocket not healing? Because maybe I need to do more scaling and root planing. Maybe I didn't freeze that area, the patient's being sensitive. Maybe we didn't get, enough root planing done because, they didn't want freezing. I kind of always think, you always say to yourself, expect that pocket isn't healing because of calculus related issues first, or biofilm related issues. And then you go the extra mile with that, and then you bring into adjunctive therapy and bring in lasers after that. So if you know without a doubt, I froze this patient last time, I went to town, we did really good root planing, and we're still no improvement, that's at the point that you can say, hey, I have a 30-minute opening after your appointment today. Really, we've tried everything now. This pocket is still active. Here's what else we can offer you. But usually in that situation, it's patients that you've seen, you've talked and mentioned lasers in the past already to them, and then you can plan for a future appointment. So, for someone that has, really active perio everywhere, you can break it down quad by quad. So you can freeze a quad, scale and root plane, use the laser in the areas that need it, and then do the same, or half mouth, or it could just be one area. Maybe it's just, 1.7, 1.6, it just hasn't been healing. Everywhere else healed up really, really nicely, and you're just looking at a localized area. So the biggest thing that I find is it's really great to educate our patients on it, let them know that we have it, and let them know that we're watching the area. Hey, today I'm going to go in, I'm going to do some really a little bit more aggressive scaling and root planing. We're going to freeze this area. We've never done that before for you. And if by next time we're still seeing the same issue, then we definitely need to look at doing something a bit more aggressive to get the disease under control. Yeah.
Wow, that's a whole process to get your mind around, and I love you sharing with us the advanced opportunities that you have in your province. So how does that work with thinking about the beginning of the appointment with the pre-procedural rinse? Are you still doing that, or because you're going to be doing bacterial elimination and decontamination, is that not necessary? So can you fill us in with that about that?
Yeah. Beth, do you want to touch on it, or do you want me to address that one?
I'll just touch on the beginning part, just reiterating the benefits kind of more on a subgingival level. And then I really liked what you and I were talking about when you were talking about the rinses you like. So maybe you could take over in a second.
Yeah, for sure.
Just to kind of circle back to what we were talking about. So with the lasers, we are targeting the bacteria kind of subgingivally. So it's going to help to reduce the bacteria that are going to be released through aerosols. Now that is again specifically targeting what is subgingival. So Chrissy, do you want to kind of take it from there? Yeah.
So I think pre-rinsing should be something that everyone should have been doing before, and it's something that I push a lot when I go into offices. Unfortunately, a lot of clinics aren't using a pre-procedural rinse, and it's one of the very first things that I implement. It's for our safety, it's for the safety of our patients, and especially again going forward, I can pretty much guarantee to you, I've had a million questions from lots of people, just the same thing. Chrissy, what do you think it's going to look like after we're through this? What are some of the changes you're anticipating? And I think a mandatory pre-procedural rinse is going to be one of them. I've been using in my clinic probably for 10 years. One of my favorites was Perio Plus. And the reason that I liked it's an antibacterial, and it has a low dose chlorhexidine and essential oils as well. So no alcohol. They have rinses that are for home rinse for your patients, but they also have a pre-procedural rinse that is stronger and meant for a pre-procedural rinse. So that's been my favorite. It's been my go-to for years and years. But going forward, I think that we're going to have to adapt what we're looking at in our ingredients in our pre-procedural rinse. Again, the research hasn't been done to completion, and we won't know for a while. Kind of the front runners are looking like iodine-related rinses or hydrogen peroxide-related rinses. And there actually are already a couple really good iodine rinses out there that don't taste gross. They're flavored nicely. And actually, really, when you look into some of the benefits of iodine, I'm actually really interested in learning more about the iodine rinses. There's one that actually came to my attention. It's called IO Rinse from IoTech International, and it's out of the States. And it looks probably one of the most promising ones, I would say, in my mind, if we end up having to go an iodine rinse. I think probably my go-to or my favorite companies that have the pre-procedural rinses, maybe they're going to adapt and open up their market to having more options as well. If we know that is something that people are going to be thinking about, and that with COVID and the virus that we need to go, something a little bit different than what we've been using in the past. When we think of a pre-procedural rinse, though, I like to call it the 80-20 rule. So 20% of what we do with laser bacterial reduction in the entire mouth of getting rid of bacteria for aerosols, 20% of that surface area is subgingivally, and we attack that with LBR. Now the rest of the mouth, there's 80% of your tongue and your cheeks and everywhere else in the oral cavity that needs to be addressed. So just because we're doing LBR, I know some clinics will say, oh, I don't do a pre-rinse anymore, because they're thinking just from a cross-contamination from pocket to pocket. That's why we're doing a pre-rinse, but we need to think the whole oral cavity. When we're thinking of aerosol and spraying a tri-syringe and that, aerosols that are created, it's not just sub-G when we're using an ultrasonic underneath the tissue, and cross-contamination from pocket to pocket. So we definitely still will need to use a pre-rinse on top of exactly what Kathleen said. Now to have the option to have lasers and for our patients to know we are attacking that bacteria and that viral load as well as we possibly can.
Excellent. Thanks, ladies.
I was going to say too, I think it's the best, again, we were saying how it's the best time now to introduce lasers, but I think also for a pre-procedural rinse, if that wasn't something that you were doing before, and it might seem a bit embarrassing now to all of a sudden say, oh, you have to do this. It doesn't need to be something embarrassing. It's use this kind of platform to introduce it into your practice. Now we know more now, or I know more today than I did yesterday, and we're making changes accordingly.
Yeah, that's my favorite quote. I have it in every lecture is, once you know better, do better, right? So it wasn't that you knew, absolutely without a doubt that you should be doing a pre-procedural rinse, but now knowing we have even more issues and concerns with aerosols, we know better now, so let's do better. Absolutely.
Very good.
So I know in my practice, I've got a lot of patients that have sensitivity, right? And I know that the laser can be used for desensitizing. Do any of you guys have some interesting stories or memorable patients? Because we all have those people that we go to and we try it on and it's like, okay, this is what made me buy in, or this is what made me want to share this information.
Yeah. Chrissy,
yeah.
You told me a story the other day and I loved it. Can you share that story?
Absolutely, yeah. So desensitizing is actually one of my favorite procedures that we can do with a laser. We all know that probably 80% of our adult population base in her practice has a sensitive tooth or sensitive teeth. So I mean, again, it's one of these things when I go into a practice with my consulting, I'm shocked at the amount of desensitizing that is not being done. We're not offering any desensitizing, never mind laser desensitizing. So I want everyone to know that it's not necessarily, the reason that I love desensitizing with the laser is not because it works way better, it's just a lot longer lasting. So you can have a lot better case acceptance on a procedure and a code that maybe might not be covered by insurance, because we do know it's not always covered. And if you say to someone, hey, in Alberta, it's about an $80 fee for desensitizing for 1 unit of desens. And so if you say, hey, I know it's not covered, this is what we can do, and we can get rid of that sensitivity, it's going to last about 3 months and then we'll have to do it again. Hopefully they'll probably go to it. But if we can say to them, hey, we can do this procedure, we can get really good desensitizing, get rid of that sensitive tooth. It's an $80 procedure and it's going to last about a year. Which sounds better to you, right? So you will get better case acceptance for sure because of just the longevity of it. But I'll tell you my personal story. So like I said, it's literally one of my favorite things to do because of the success that I've seen. So I've done a couple full mouth desensitizing, meaning like every tooth had recession and every tooth was hypersensitive. So the two that I have in mind that I did a full mouth, now it's very time consuming. It took about an hour and a half and it's very monotonous, and you feel like if you did that a lot, you'd get carpal tunnel because it's a very small movement when you're doing that. But these are the kind of patients, these two that I have in mind, they're the ones that come in that they literally hate coming in because their teeth are so sensitive. They don't want to even come in for the hygiene visit. They do it because they know they have to, but literally almost every tooth we ended up having to freeze just to touch to scale along the root surface. So that kind of sensitivity. And so, you know, we had done topical, which worked quite well for the thermal sensitivity, but tactile sensitivity, I just found wasn't working for her. Every time we just barely touched the root, it was super sensitive, which led us having to freeze to do hygiene. So I said, you know what, we have this new technology, we can desensitize teeth. Let's you know, have a go at it. And I actually desensitized a couple teeth, tested it, and then she was like, wow, that is really good. So we ended up doing her whole mouth, and it was probably 90% of her teeth had recession and sensitivity. And when I was done, so I'm like, okay, you know, you finish and you kind of say, like, you blow some air and water, are we done, or do we need to keep doing more? And she actually got tears in her eyes and she started crying. And I was like, are you okay? And she goes, I'm so okay. She said she hadn't remembered, like, since she was a teenager, being able to blow air or cold water on her teeth. And she was just like over the moon, and I was super happy of how well it worked. And when she came back for her 3-month visit, she actually cried again and told me that I had changed her life. And I was just like, that is amazing, right? Like, we all have these stories how we can impact our patients. So to add to that, I tell this story now every time I do a laser course. So I'm in my last laser course, I told the story on day 1 in my didactic. Day 2 comes and we're working hands-on on patients. And we have a patient in the chair that has one really sensitive tooth. I think it was the 1-4, like can't touch it with a scaler. So anyway, she says, oh no, you know, they've tried everything before. They said, well, maybe, you know, we need to freeze it. And I said, well, do what you need to do. So they actually even infiltrated, froze it, and she was still sensitive. And I was like, that's crazy. And so I said, well, girls, now's the perfect time. Why don't we try to desense with the laser? Maybe we'll get some better success. We did, and she cried in the chair, and I was like, oh. And so she said the same thing, like she couldn't remember a time, and like they had tried everything at her office that she was going to try to get that tooth not sensitive for her. And she was like, I can't remember ever not feeling sensitive on that tooth. And the hygienist looked at me and she said, did you pay her to say that? Because it was like exactly the story that I told the day before. I'm like, I did not pay her to say that.
That's awesome.
Yeah, sensitizing is honestly one of my favorite things that we can do with the laser.
That's amazing.
Mm-hmm.
Yeah, that's so good. Chrissy, we're just getting a couple of questions coming in. One of them was talking about LBR. So the question was, do you do it just in specific sites, or do you go towards the deeper ones? So my opinion on that, and again, laser bacterial reduction, LBR, it's a very quick procedure. You're really only inside the pocket of a tooth for, you know, 30 seconds. So not even 30 seconds, it's quite quick. So I don't believe we should just be targeting the specific sites that are the deepest. I think we should go all over because bacteria can move around. So chances are if it's in one pocket, that bacteria is in the next pocket. So for laser bacterial reduction, I choose to do it full mouth. And just to reiterate as well and answer another question, laser bacterial reduction is a pre-procedural, therapeutic procedure, and it's to reduce the bacteria in the pockets so that when you are doing your debridement, you're reducing the amount of bacteria going into the bloodstream. Also, again, reducing the bacteria in the aerosols being produced. LAPT, on the other hand, which is laser-assisted periodontal therapy, is a different procedure, and that is typically done post-scaling and replaning. Is there anything you want to add to that, Chrissy?
No, I think you explained that pretty well. Again, I think it's important in trying to differentiate. I mean, it seems very easy for us because we know the terms, but just think to yourself that they're meant for two totally separate things. LBR, laser bacterial reduction, is meant for everywhere, and it's meant to prevent disease. So we're doing it everywhere, even on healthy people. We're doing it prior to the disease process, where LAPT is once there is disease, we're using it to treat the disease. So if you think of it that way, it kind of clarifies it a little bit. Yeah.
For sure. And I wanted to touch on too, when we're talking about desensitization, I know it's a different procedure, but with the oral lesions, I had a little boy come and he had a huge aphthous ulcer, and he came in, honestly, he just came in because his mother felt too guilty canceling. But she said to me, poor little Jimmy, I'm going to use the name Jimmy, hasn't eaten, you know, in 2 days, and he just has this really painful canker sore. So I'm sorry, but we can't proceed today. So I said, would you mind if I tried the laser? So I did the laser procedure. And like we were talking about, we are taking away the symptoms. We're not taking the lesion away. We're speeding the healing, but we're also taking the symptoms away. So he just jumped out of the chair and he thought that I was magic and that I had taken away this lesion for him when I hadn't. It was still there, but he couldn't feel it anymore. So he went home and had lunch, and his mom called to tell me that he was, you know, my new BFF and my client for life. Yeah.
That's so nice.
Maybe now that we're talking about personal stories, I'm going to tell you one more. Now, this doesn't have to do with desensitizing. It has to do with low-level light therapy. So we'll talk a little bit more about that in a little while. But the laser that I use in my clinic is the Zolar Photon laser, and it's the first one in Canada that actually has the availability to be, you know, a cutting tool in dentistry for our parameters of all the procedures that we can do in hygiene, but also low-level light therapy. And low-level light therapy has been used for years in other professions, so massage and chiropractor and physiotherapy, and they obviously have medical ones that are bigger, but they're using it for inflammation and helping to heal tissue trauma, muscle pain, that kind of thing. So my personal story is actually about myself, and it's about my Tmj pain. Last year, I'm a grinder, I wear a Brex appliance, and that usually, you know, has kept me good. I haven't had Tmj pain. And all of a sudden, out of nowhere, really, I try to think back of what changed that started it all, and I can't really think. But I was getting to the point that I was taking Advil every single day, and I couldn't chew gum anymore. I'm a big gum chewer. For all the girls that know me, they're gonna laugh because that's like, gum is like my favorite thing. I chew gum all the time. And so I was devastated. I couldn't chew my gum, and you know, my jaw hurt every day. And you know, the worst is taking the Advil. Advil's not good for you, and it was every day. So I actually went to my boss and I had him inject Botox for me, and that worked. It was great, but it only lasted 2 months. So I was like, okay, well, that worked really great. Let's do it again. And then the next time was even shorter. And so again, a great therapy, but I was like, I can't keep doing this amount of Botox in my jaw every 2 to 3 months for the rest of my life, or however long it's going to happen. So I looked to other options. And again, knowing that the low-level light therapy option is right built into the Zolar laser, it was a no-brainer for me. I was like, well, it's worth a try, right? We hadn't implemented that portion into our practice. And so just to be clear, to treat TMJ or disorders has to be the dentist. It cannot be the hygienist, because it's out of our scope of practice to treat TMD disorder. And so I had that done on me. And what you're going to do, and it's honestly literally the fastest, easy procedure. If you have a patient come in, like we joke, I'm like, this is the fastest, easy procedure you'll ever have done in the dental chair. It literally takes a minute and a half on either side, and you feel nothing. There's nothing. So you almost feel like, is it doing anything? And you're going to do, they usually say 8 to 10 sessions, 2 to 3 days apart. So I was probably on my 6th session, and I was like, oh, it's not working. Like, I'm not feeling anything, no improvement. 7th session, I was like, oh, you know what? I feel like it's not hurting as much. Like today, I actually didn't take Advil. And then all of a sudden at the 8th session, I woke up one day and it was completely gone. Like, felt. And so I was like, okay, we'll see then, now that we're done, you know, the treatment, we'll see how fast it comes back. Well, I'm now over a year later, and I've only had 2 times during that session, or during that time period, that I started to feel it was kind of feeling tight and sore again. So we just topped it up with one session, and it was good again for about another 4 months. So for me, I'm chewing gum, like I can even do the things that would irritate your jaw, and it's like 100%.
Wow.
So again, not that we as hygienists can do that, but again, another selling point when we get into talking about investing, you know, getting your boss on board to invest in the technology, to be able to offer that. Maybe they don't offer Botox, or maybe we do, because in our practice we do, but we have availability on someone that maybe doesn't have the availability to spend that much money, or doesn't, you know, want to go the route of using Botox. You have a much safer and cheaper option for them.
Great.
So, yeah.
One of the things is, I don't know, I always hear, like, it's one of those myths that there's no science to support the use of laser in the dental hygiene practice. So can you guys talk on that?
Yeah, for sure. So we go through, in my full day course, I go through the studies in great detail. I get a bit passionate about it, so I always have to kind of check in to make sure no one's falling asleep in my class. But I just think it's so important, right? Anything that we're doing, we want to have the science to support us. So there is a lot of research out there. And unfortunately, or maybe fortunately for all of you, we don't have time to go through every study. So what I've asked Kathleen to do is to send out sort of my favorite ones in a follow-up email to today. So we're just going to give you the articles or the studies that we've kind of pulled together to do our research for our courses. But I will go through a couple of things. So anytime you're looking at a study, especially I'm going to talk specifically to lasers, the important question to ask before looking at a study is that study putting laser therapy as a monotherapy? Because that was never the claim. This is an adjunctive therapy, so it's something we're doing in adjunct to scaling and root planing. So if a study is saying they're not for lasers because they were studying it as a monotherapy, that's not what we're claiming. Okay, so that's the first question to ask yourself. The second would be that any research, they need to take into consideration potential for harm. If a laser is not utilized properly, there is potential for harm to the root surfaces, to cementum, sulcular epithelium. So safety measures are in place. You need to take training. So you need to be using the proper settings. If you're not, there's risk for harm. The third thing is, what are the therapeutic endpoints that they are looking at? So if it's just simply looking at clinical attachment levels, is that the true picture? Is that the full picture of what's going on? Have we achieved health? Can we simply look at CAL as our indicator for that? So those are just some questions to ask. The studies that I'm going to send you, or that Kathleen's going to be sending you, some of my favorite ones do highlight a reduction in bleeding upon probing. So the reason those are my favorite studies is because if there's bleeding, I know there's active disease. If we're getting a reduction in bleeding, then we're reducing that disease activity. The other studies show that there was a significant reduction in keystone pathogens. So for instance, P. gingivalis. So if anyone has studied P. gingivalis, you know that that bacteria is not messing around. They are highly intelligent. They communicate with each other. They can affect other bacteria and make them more virulent. So it's not something to mess around with. So the fact that P. gingivalis is one of those bacteria that are specifically targeted is a big deal. Other inflammatory mediators were also reduced, and they also showed that the colonies were reduced, but also that it delayed the recolonization for up to about 60 days. And that 60-day mark is very significant for our periodontal patients, right? So when they come back, we're going to use the laser again, reduce the bacterial colonies, and keep them reduced for another 60 days, or up to 60 days, I should say. Another study showed that there was a reduction of MMPs, and it was particularly MMP8, which, as we know, is collagenase. So collagenase attacks collagen, and in the oral cavity, as well as systemically, collagen is kind of a hot commodity, so we don't want those MMPs destroying the collagen. So take a look at those studies. For me, it was what I needed to not only get on board with lasers and teaching lasers, but it also got me really excited. So please read them. They are excellent, and I'm hoping that that will solidify your belief in lasers.
So you're going to send those to me and I'll share them.
Exactly, yes.
So for all of you who are on here now or watching later, we'll have an address to type in, so that way I know that I'll send you all the extra resources and a link to watch this again. Okay, we'll talk about that at the end. I think Carrie's going to put it up on the screen.
Thanks.
Okay.
Can I add to that too, and not just talking about the studies, but I think we need to remember that people don't like change. They want to just keep using what they're used to using, and they don't like getting out of their comfort zone. And when we talk about technology in dentistry, it's very well known, and this is kind of what they say in the industry, it takes about 20 years before a new technology becomes mainstream. So that means that everyone knows about it, everyone's using it, that there's enough research that everyone feels comfortable using it. When we think back to bringing ultrasonics into our daily use, people were nervous to use ultrasonics. They thought it's going to harm the tooth, it's going to wreck the root surface. You know, that when we brought that into play years and years and years ago, it was not mainstream, and there was a lot of people that didn't want to use it. Now, can you imagine doing practice without it? And that's what I think about any and all of the adjunctive therapies that I bring into play. I don't just have lasers in my clinic. I offer every and all adjunctive therapy that I humanly know is possible to offer to our patients, because sometimes one might work better than another. There might be a reason that you choose something, a local antibiotic, over using laser in an area. And again, in our courses, we kind of talk about where and how you do case selection for using lasers and where you might use a different adjunctive therapy. And then sometimes you use them together. So something like Periostat, I use, you know, host modulation with laser. You don't just want to think one thing at a time. My most successful cases that I've had that I use for examples in my course are patients that I did multiple modalities. So both of them were actually had heart attacks and they had diabetes. And we did quadrant therapy, scaling root planing. They were on Periostat. We did the oral vital bacterial testing. They were both very high on that spectrum. Did the oral rinse, antibiotic rinse, and then we did lasers. And it was the most miraculous healing I've ever seen. Like outside of having surgery at a perio office, it was pretty crazy. Like I'm talking 8mm pockets down to 3s.
Wow.
Yeah, so it's
amazing.
And he's actually he's been my one gentleman, he's just the most awesome patient ever, but he's been one of my practice patients in every clinical course I've held for lasers. He just loves having it done, and there's always other areas to treat and retreat and desensitize, and so yeah, it's awesome.
Can I interject for a second? There are a few questions that keep coming up, and I want to make sure we've got about 10 minutes, maybe 15 minutes left at the most, and I kind of want to touch on a few of them. One was just to clarify, can all hygienists do use lasers with the canker sores, or is that only in specific provinces?
Specific provinces. Right now it would be Alberta. You just got the ability to do that recently, correct, Chrissy?
Yeah. Yeah,
and
so we used to be able to do it, and then they took it away, and now it's back.
Now it's back.
Okay.
In Ontario as well. BC, unfortunately, no.
Okay. And another question was, I guess it must be an independent hygienist. They asked, does a dentist have to buy the laser, or can somebody else purchase it? And what is the average price of a laser?
Yeah, anyone can purchase one. Yeah. And as long as you've taken your training, you're laser certified to use a laser. Obviously, you're not going to have one in your practice if you're not certified. And maybe we'll get into pricing a little bit at the end when we talk about rate on return. How about that?
Okay. If you want to go into that right now, because that seems to be quite a few questions that are coming up on, you know, how do I talk about it? What do I do? How do I pay for it? What do I say to my boss in a sort of a fairly summarized version? Because I know I've taken in all the stuff that you guys have been saying, and I've been trying to manage some of the chats, but it's overwhelming. And I know to take your full day courses and put it into an hour, this is just a snippet, a summary of it that, you know, you need to attend a course, even if you don't want to implement or you don't have that opportunity, just to gather the information would be helpful. But I'll be quiet and I'll let you answer the question.
Sure. Okay, so maybe what I'll do is I'll get into just my experience on how I implemented lasers into my clinic, and ROE will come into that. So what I love about lasers is there isn't just one way to implement it in your clinic. So if you're maybe someone like me and you were like, I'm going to try it for myself and I'll determine if we like it and we're going to use it, then maybe we'll train the rest of the staff. And that's how I approached it. So for our clinic, we have a very large hygiene team. We have 9 hygienists. We run 6 hygiene chairs a day. Obviously, if I went to my boss and said, hey, boss, you know, I hear about this technology. I hear it's good. Can we please buy 6 lasers and train all 9 hygienists? You know, obviously he's not going to be sold on that. So for me, I said, hey, we have a diode laser sitting in the cupboard that no one's using. I saw that there's this laser course. Would I be able to take it? And we'll see what kind of results we get from it. He's like, sure. So no real initial investment, since a lot of practices actually usually have a diode already that the doctor may be using intermittently. And from that point, did it. And like I said, I was the sole provider for laser in my clinic for the first few months until I started to see my reevals. And once I saw what the laser achieved and the good results and the good feedback and case acceptance, then I was like, it's a no-brainer. So I put together the package, I put together, okay, this is what we've done. This is what now that I've done it, I see the case acceptance is actually really good. I see what insurance is covering. Hey boss, here's the plan. I think it's an amazing technology. I think every hygienist in the clinic should have it. If you're wanting to fully utilize lasers and implement it to its full capability, every hygienist is going to need a laser in their operatory. I have seen clinics that have shared one laser for 2 hygienists. It makes it a little bit difficult, but it's doable. So if that's the only way you can go about it, still better than nothing. I've also seen where there's one person that will be like the laser guru of the office, and they're doing the herpetic lesions and the LAPT in Alberta. The only thing that you can achieve then is not all your patients are going to benefit from LBR, because not one hygienist can do everyone, right? So if you're doing it at the beginning of the appointment, but you can still do all those other modalities, everything else, the other procedures that are available. Or you can do it like I did, see for yourself, bring it into your clinic and just fully implement it. So basically, lasers are one of the fastest rate on return out of any technology in dentistry today. Quite typically, a lot of the big, ticket items usually take, 6 months, a year, even up to a couple of years to pay off with the water laser type lasers, things like that. But the diode lasers are very reasonably priced, and that's what makes them a really good adjunct to be able to actually implement and to have multiple per hygienist. So usually I'd say anywhere between just under 4,000 to about 6,000 is the range that you're going to pay for a diode laser. In my practice, we have 6 of the Zolar photon lasers. It is my favorite. It's what I'm comfortable with. It's easy to use, and it also has that low level light therapy setting, which I talked about with the TMJ, which is really good. And so that one is just under the $4,000 mark. So really good price point, and your rate on return, when you put those numbers together, it's usually about 2 months is only how long it's going to take to pay off that laser. So, and then going forward, everything else is now extra production. Yeah, go ahead.
What's different? Oh, sorry, I was just going to say, got a question. We just got a question on the laser that you were just talking about and who to contact if they were interested in getting that one. So in Ontario, it would be your oral science reps, and it's the same for you, correct? Yeah. Oral science reps.
Yeah, across the country. I think it's all oral science, yeah.
Can one of you ladies just quickly summarize a bit of what the difference is between that and PerioWave? Because PerioWave was a big product quite a few years ago. A lot of people have that laser in their office, and there have been a few questions that came in. Can one of you just summarize a bit of the differences or similarities about it?
So I actually used PerioWave back in the day when it was available. I don't even know if you can still get parts and such for it. Yeah. So a little bit of a different technology. They still consider, and actually a lot of people that are using PerioWave don't actually know this. In Alberta, I'm not sure about the other provinces. They do consider PerioWave a class 4 laser, which actually puts you in the category of having to take the full laser 2-day course in Alberta. And a lot of them that were using it from years and years ago got trained by the rep, and that's the extent of the training they had on it. So, and just FYI, if you are using PerioWave in your clinic and you haven't taken that full 2-day course in Alberta, it is considered a class 4 laser, but much different. And I'll be honest with you, I didn't really see results with PerioWave. I maybe had a tiny bit of reduction of bleeding, but I didn't really see a reduction of pocket depth ever. And that was my own personal experience with it in comparison to what the diode laser does, totally different. Yeah, I mean, same kind of capability. So when you apply the solution under the gum, it attracts to the gram-negative, the harmful bacteria. And then the PerioWave was supposed to ablate or blow up the bacteria. Again, I can't say into the technology of how it worked different in terms, but it was not a diode laser, a different technology. Same concept as what they stated it will do, but I found my own personal experience, it barely worked for me. Yeah.
That was my experience as well.
Yeah. So I just want to go back really quick because I know we don't have very much longer. I just want to tell people about, again, going back to how I implemented. So we have a diode laser in every operatory. It's available then to do at the beginning of the appointment for LBR. It's available then if the patient's sensitive, we can throw in that desense in the moment, treat a herpetic lesion, add LAPT or book LAPT. And from there, so again, I'm a firm believer of keeping track of your success or are things working? You know, what kind of patients are we getting good results on? So from the very beginning in my clinic, I have kept a log of every patient we've ever completed LAPT on, laser-assisted periodontal therapy. So we've got the patient name, the date that we did it, the pockets that we treated. We've got our follow-up at the 3-month mark. We then have 1 year. What do things look like 1 year later? Now, think to yourself, all of these pockets that we treated were pockets that were there that we couldn't get improvement with scaling and replaning. So we had done whatever we could with our gold standard and it was still active. We couldn't get it under control and now we went to adjunctive therapy. So we weren't getting any results with scaling and replaning on these pockets. Now going to LAPT, we're at still currently 85% success on getting those pockets. Reduction of pockets by 1 to 2 millimeters is the typical. Reduction of bleeding, huge. And like I'm going to tell you, infurcations, I've had cases, like I said, come down from 8 to 3s. So wow. Pretty like significant enough in that one case that I told you about that he was on the periostat and everything. He had been seeing a periodontist and we actually didn't get much improvement for him. But again, I think for him, they weren't looking at host modulation therapy and all of those outside things that we fully look at, the bacterial testing. They were just looking at a surgical modality. And for him, it just didn't do the trick. And for us, incorporating all of those things together really worked wonders for him. So yeah, I think that was all I wanted to touch on. So ROE, yeah. So if you are trying to convince your boss into, hey, this is something, it's a technology I'm interested in. Number one, obviously we need to take a course on it to be able to do it. But if you already have a diode laser in your office, then wonderful. And you can always start with one and work your way up, right? So if you have one and you realize, wow, this is awesome and we're fighting over it, we need more. I mean, you can definitely look at buying more. And that price point, I mean, you know, 2 months for a radome return on something in dental is unheard of.
Yeah,
that's great.
So as far as
training,
education goes, can you ladies just outline what we would need to do to make sure that we were certified?
For sure. So across Canada, the provinces that allow the hygienists to use the laser, the one thing they have in common is the fact that proper training needs to take place, and the training has to include both a didactic or theoretical and a hands-on portion. So it wouldn't be enough to just take the DVD training that sometimes comes with the lasers. You have to actually go to a course that provides that hands-on. So we are actually going to put the theory part in an online format for right now. We've had a really big demand for laser training, and we want those people who want laser training to have it. So what we're going to do is we're going to actually have that theory portion online, and then we're going to set a day, and maybe Kathleen, if you want to talk about this, we're going to set a day, hopefully in the summer we'll be able to meet in person and kind of choose your time slot, and we will do your hands-on portion that day.
Yeah, I think so. I think the online training we're going to do takes over 3 days. I do have the dates here, but I'll send that out in the email as well. I don't know if you know the dates, Beth, and then once we can get out of being quarantined, then we'll just pick some dates, and then you can come to RDHU for a few hours to get certified, then to receive your nice beautiful frame certificate and feel good about that. So we do have some courses coming up that are at RDHU, and we just kind of bumping them. Hopefully we'll be back, I don't know, June, I don't know, who knows, but a lot of people are wanting us to do the online, so we thought we may as well be this kind of format. So we're going to do that while we're home. A lot of people want to take advantage of this time, and then when the nice days are here, it's less time in taking a course for your hands-on. Yeah.
Now, can I just ask, sorry.
I was just going to say, it's okay.
I was going to touch on Alberta. So Alberta's a little bit different. We're a 2-day course. Day 1 theory, and day 2 is actually live patients. So we actually have patients. It's a little bit different when you're doing LBR. You can practice on each other for the hands-on, but when you're dealing with LAPT, you have to have a perio pocket to work on. So we actually have patients with perio to work on, and that's another day. So I'm totally open to doing the same, offering that day 1 theory if people want to take advantage while we're off. Get that done and break it down into a few webinar type style. And then when we're ready and able to go back, then we can work on that patient day for sure. So if there's a demand for it in Alberta, maybe they can reach out to RDHU. And if there's a demand for it, then I can put that together too.
That's perfect. Thanks, Chrissy.
One other common question that kept coming in was, can lasers be used around implants? And I know we're right at our time, but you can use a laser around an implant, can you, or can you not?
You can.
Okay, perfect.
You want to talk? Okay. So I imagine, so LBR an absolute, like you can do it around anything, but LAPT, same thing. So again, it's like anything, you need to be using it correctly. Always when we're doing LAPT, we're aiming that laser initiated tip towards the epithelial lining, not towards the tooth or the root. So exactly the same with an implant. I've actually read some interesting articles and research papers to do the more, that we're dealing with implants. We have to realize that now that we're seeing more implants, we're also starting to see more failure of implants. And about 10% of all implants are failing at some point, and they're even up to 20% at that 5 to 10 year window. So I don't know about you ladies, but I know I teach this a lot in my adjunctive therapies and my advanced perio. We need a better way to manage those implants. So scaling is not the answer. There's not a lot of calculus removal. That's not really what we're aiming. We're aiming for biofilm removal, so airflow, debridement is really important, and also utilizing bacterial reduction in that way as well. I use the laser on my husband's implant. He was having a failing implant. Unfortunately, it was occlusion and an issue that we couldn't fix with the laser, but we absolutely, I attempted. I said to my boss, I'm not taking that thing out until I've got a chance to try and see what I can do with the laser first. But unfortunately, it was too far gone. Is that all, ladies?
That's great. Yeah. Thanks for sharing so much. That was really informative. I learned tons today.
Good. Well, thank you so much for having me. I enjoy working with you ladies and getting to spend time with like-minded and passionate people in our industry. It's just a pleasure. So
thank you. And thank you to everybody for joining us today. We really love having you here. And like I said, if you go to www.rdhu.ca/lasers view, the web form will be there. And so you just sign up for that, and then we'll send you the extra studies that Beth's going to send me that she was talking about. And we have a couple other things that we're going to add to layer this as well. So we will send you a follow-up email. So go to rdhu.ca/lasers with an S, lasers view, as in the RDH view.
Kathleen, one thing I wanted to add, I forgot. I'm going to add this to your resource, but I know a lot of people always ask me what's a good resource that I can order and pre-read before a course, things like that. This is one of the best textbooks. I know it's so soft tissue lasers and dental hygiene. It's the only specific textbook that I've been able to find that's for lasers and hygiene. So we'll add that one.
Excellent.
All right. Well, thank you so much, everybody, and enjoy your afternoon, and we'll see you again.
Bye, everybody.
Bye.
Bye.